My name is Vaneeta Bamba, and I will talk about growth from birth through puberty. And you notice I only went to puberty, and that's because during the next discussion on puberty, we'll talk a little bit about growth. And what I think is a little bit interesting about these two topics is whether you're an endocrinologist, a nephrologist, a neonatologist, a general pediatrician, or have children somewhere in your life, you'll probably learn something. And so I often will use this even for my own children and for my own friends. So that's what I think is, and I think that you can probably get a little bit out of all of our lectures related to general pediatrics, regardless of where you are. So am I okay to start? Everybody okay? Okay. So I thought we would start with just the objectives first. Our goals today for this lecture over the next hour are to review the normal processes for growth in children and adolescents, to discuss the endocrine management of common growth disorders cared for by pediatricians and pediatric endocrinologists. And then my goal is to make you an expert in all of these conditions, okay? And you'll see that theme recurring. So a brief outline of how we will proceed. First, we'll start with reviewing the normal growth patterns in children and adolescents. Then we will review the reasons you might consider thinking more about somebody's growth. And then we'll talk about evaluation and treatment of these conditions, okay? How am I doing speed? Too fast? Too slow? Okay, let me know if I'm too fast. So we'll start with definitions. And a lot of my talks will talk about definitions. We'll start with definitions. So what is height? What is normal? What is abnormal? How does it relate to growth? So I want to point out that height is a single static measurement, right? So I can tell you an individual is 48 inches tall, or let's say centimeters, 100 centimeters tall. Depends on how old that person is, right? So if that's a 5-year-old, 100 centimeters is on target. If that's a 6-month-old, that's very abnormal, right? And if that's a 16-year-old, it's also very abnormal. So height itself can be abnormal, but it must depend on other environmental situations. Growth, on the other hand, is really a dynamic measurement. It's how many centimeters you're growing over time. One can be normal in the setting of the other one being abnormal. So if I told you that somebody was growing 20 centimeters a year, that sounds very high. But if you're talking about an infant, that's not very quick, or that's pretty normal. If you're talking about a 15-year-old, that's rather fast, okay? And so we'll review all of these as we move through the talk today. So I really think of growth as being divided into 4 sections, or 4 phases. First is the prenatal growth period during the pregnancy. Then there's growth during infancy, growth during childhood, and then growth during puberty. And you can see the rate of the height velocity through this slide. But what's really important to recognize is that different factors, including hormones, but not just limited to hormones, are of variable importance in each phase, okay? Causes of poor growth during one phase may be very different than what you might expect in a different phase. However, what's important to recognize is that if you have one phase that's characterized by poor growth, that may impact the growth later on. And so later catch-up potential could be limited. And again, we'll talk about those situations. So first, we'll talk about prenatal growth. Prenatal growth can be very heavily influenced by a number of prenatal factors, including maternal factors, such as diabetes or hyperglycemia, or maternal infections, such as CMV. Fetal factors may include genetic conditions, so maybe perhaps trisomy 21, or other conditions that may impact their growth. Environmental factors, such as a uterus that may be inadequately sized, or placental insufficiency, may also contribute to slow growth in the fetus. What's important to remember is that insulin during that prenatal phase can be a large growth promoter, so that can contribute to large fetal size. And insulin is more potent during the prenatal phase than thyroxine or growth hormone. It's also important to remember that birth size, the size of the baby, does not necessarily equate to adult height. So a small baby doesn't necessarily mean that they're going to be a short adult, and vice versa. It is important to recognize, though, that a factor such as intrauterine growth retardation, which is an example of growth impacting an entire phase, may have limiting effects later on in terms of catch-up growth. Okay? Our next phase is growth during infancy. So this is a pretty rapid phase of growth. It may be impacted by congenital diseases. It may be impacted by nutrition. And so, in fact, infants are very susceptible to undernutrition. If they're not getting enough calories, they're quickly not going to grow appropriately, grow in height appropriately. Thyroxine is essential. And I'll repeat this again. Thyroid hormone is essential to growth in the infancy phase. Okay? Growth hormone slowly becomes important, not so much during infancy, but into the toddler years and then throughout the childhood years. Genetic height is not that important in the infancy growth phase. However, this is also slowly going to become influential as they become toddlers and children and adolescents. Childhood growth is probably the one period where you expect to see the most consistent growth. Yes, there's a question. Right, so the growth hormone with regards to growth starts to become important. So the question is, when does growth hormone begin to be important for growth? It starts to become important around the age of 3, certainly by the age of 5. And it's not that it has no impact on the growth, it's just not as potent as many of the other hormones. And growth hormone itself is actually important with hypoglycemia, preventing hypoglycemia, which we'll cover later on. Yeah. Yes? Yes. Yes. I'm sorry, say it again. Growth factors, insulin-like growth factors. Mm-hmm. I didn't. So IGF-2 is important for prenatal growth. But you're right, I did not include that in this slide. Yes, but IGF-2 is important for growth during the infantile phase. Any other questions? Okay. So childhood growth is probably, as I mentioned, the most predictable phase. Most children, not all, but most, are going to follow a consistent percentile during childhood. Growth hormone and thyroxine are also very important for growth at this age, whereas insulin is a little bit less important. And sex hormones, because most children are not making sex hormones during childhood, is also less important for growth. Obesity, however, will gradually increase the height velocity. Okay? So adolescent growth is probably the trickiest. This is the most variable phase of growth out of throughout childhood and adolescence. It is particularly important to have sex hormones, which will stimulate the pubertal growth spurt, which we'll come to later. Growth hormone, nutrition, thyroxine again, as will all positively influence growth. Infection and chronic inflammation can negatively influence growth, and certainly genetics, both family genetics, right? How tall your parents are, how tall your family members are, that's going to influence how you grow during puberty. But also genetic conditions may influence how you grow during puberty. Okay? And again, we'll do some specific examples of these later on as we talk about pathological causes of growth. So this is a busy slide. Raise your hand, please, if you've ever used a height velocity curve or seen a height velocity curve. Okay, so this is new for most of you. There are a few of you who have seen it. How about growth curves for height and weight? Do you use those in your practice? Yes. So very similar. This can be very confusing, so I will walk you through it, okay? So just as with our standard growth curves, you've got your age on the x-axis, and you've got the height on the y-axis, except it's not height, it is height velocity, so centimeters per year. And you can see grossly, we'll go into the details of this, but you can see grossly how the height velocity changes over the years as a child is growing, right? And then you get that dip, and then that peak up, and then it drops again, okay? So we'll go to the next slide. Now we're going to look at the details of this. So height velocity will vary by age, sex, and your genetic potential, right? So children who have tall parents, they're destined to have a faster height velocity because they have to get to that taller height. Children who have shorter parents or shorter genetics, they're going to grow a little bit more slowly, and so they're going to grow at perhaps a lower velocity. I believe this is a boy, but it doesn't really matter. This is just for example purposes. We'll get to the specifics in the next slide. In the first 2 years of growth, which is actually not shown on this slide goes from ages 2 to 18, but the first 2 years, as I mentioned earlier, there is rapid growth. So if you've ever seen a newborn or bought clothes for a newborn, they outgrow those newborn clothes before you even take them home from the hospital, right? They grow very, very rapidly. And then the growth starts to slow down around the age of 2. You can see the 50th percentile, which is that dark line, is about 9 centimeters per year, if I'm reading that correctly. But by the age of 5, it drops all the way down to 7. Is that right? 6.5 centimeters per year. So it is rapidly dropping. So you see this gradual slowing of height velocity over time throughout childhood. And then when you get to puberty, you get this big bump again, right? So that's your growth spurt. And your growth spurt, your pubertal growth spurt or growth acceleration typically will account for approximately 15% of your adult height. So now we're going to go into some details. Height velocity for boys, this is specific to boys, around the ages of 11 and 12, on average, they will have a deceleration in their growth as they start to enter puberty and as they get into the very earlier stages of puberty. So most boys will actually slow down in their growth before they start to pick back up again. And that's an important point to remember when you think about children who are delayed when they go through puberty. So here you have a slowing of the growth right before the pubertal growth acceleration. And we call that their growth nadir. So now we're looking at boys and girls. So boys on the left, girls on the right. So now we're going to look at the peak height velocity. On the left for the boys, their peak height velocity occurs around the age of 13 to 14, again with the average timing of puberty, and they grow about 6 to 12 centimeters per year. On the other hand, the girls, they reach their peak height velocity a little bit earlier, and they grow a little bit slower. So they reach their peak height velocity between the ages of 11 and 12, and they grow generally 6 to 10.5 centimeters per year. My daughter is 12, and she's recently going through her growth spurt, and sometimes I think she is literally growing overnight. She will wake up in the morning, and she is about 5 or 6 inches taller than I am. And I think it's incredible, but you can't always see that, right? So most of the time families will come to you and say, he's not growing, she's not growing. So you have to make sure you get these height measurements, because sometimes when you see the children day to day, sometimes you see it, but often you don't, okay? So again, adolescent growth in girls, their growth acceleration happens during the early stages of puberty. In boys, growth acceleration happens towards the later stages of puberty, so middle to late stages. Boys achieve a greater height velocity than girls, as I showed you earlier, and they actually grow for about 2 years longer than girls. And so that actually explains the reason why there's a height difference between males and females, about 13 centimeters. So that 13 centimeters are going to come back to you. Anybody know what I'm referring to with the 13 centimeters? Yes, okay. Excellent. Okay, so you'll find out for those of you that don't in a moment. So now we're going to think about what are the reasons you might assess a child's growth, right? So I think of this in 3 categories or 3 buckets, either short stature or inconsistent growth over time or suspicion for an underlying condition. Short stature can have a lot of different definitions, but generally, length or height below the normal range. Everyone's definition of normal is different. I might say 50th, you might say 5th, you might say 25th. We generally say less than the 5th percentile. However, the other caveat to this is, does the child have a height that's below the range expected for family? So if you have tall parents, again, you might not expect a child to be growing at a lower height percentile. The second group, children with inconsistent growth over time, that may manifest as a subnormal growth velocity. So now you know how to plot the growth velocity, or the height velocity, I should say. So if you see that that is decelerating, that's a concern. But an easier way to tell is looking at their standard growth chart. Are they dropping percentiles, right? So that would be inconsistent growth. Or if they have a low annual height velocity. Or, again, that third bucket, if you have suspicion for an underlying condition. So let's say you see a child and it's a short girl, or even let's say it's a short girl and she has multiple health issues. You might think, well, I think there's an underlying health condition. You know, I'm biased. I always talk about Turner syndrome. You'll probably hear it 100 times when I'm up here in one day. But if you think about a genetic condition, that might be another reason you might want to assess their growth. Okay? And in many cases, we are able to diagnose and treat endocrine conditions that affect their growth. Okay? So we're going to talk about how to measure the patient, because if you can't measure the patient properly, then you really can't get very far, right? So we're going to focus on the left side, and the right side are just some photos for you. So on the left, we talk about how to measure a child. So we use a stadiometer, but you really don't need a fancy device. What you really need is a fixed vertical backboard, a fixed floorboard that's straight, and a movable headboard. The movable headboard is negotiable. So I say my little budding endocrinologist up here, so he's doing a fantastic job, and so is the gentleman at the bottom as well. They have the child standing up against a door frame. It's not ideal, but it is a vertical fixed backboard, right? The floor, we're gonna pretend the floor is straight, right? The floor is straight, and then they're using a device to sort of get a vertical height, okay? So that's the first step. The second step is making sure that the shoulders, the bottom or the buttocks, and the heels are touching the wall. And so you can see my friend up at the top, my 8-year-old budding endocrinologist, has presumably his sister, has her shoulders, buttocks, and heels up against the door frame. Now I'm looking at it more carefully. Maybe her heels are not quite there. But if you look at the bottom, her heels are definitely far away, okay? And then it's also really important to say shoulders relaxed. A lot of times we measure children, we say stand as tall as you can, but that's going to inflate, right? So then when you have them come back the next time and their shoulders are relaxed, they're going to look like they lost height. Children don't generally shrink, right? So you want to make sure that they're relaxed. The other thing you want to do is make sure that they're in the Frankfurt plane. So the Frankfurt plane, by definition, means that the outer epicanthus of the eyes form a straight horizontal line with the middle of the ear, okay? The other way to do it is I usually will have a child correctly positioned, and then I use the palms of my hand right over their ears to make sure that their head is straight, okay? Because when they tip their head this way or they tip their head that way, you're gonna end up with a measurement that's not correct. The other important things are to make sure the kids have their shoes off. I can't tell you how many times we walk by and somebody's being measured. Of course, never in endocrine, only other divisions. But the children have their shoes on, or they're standing on their toes. Their shoes have to be off. Their heels have to be touching the ground. They should wear light clothing, so not 6 layers, right? And then really importantly, if they have any hair ornaments, bun, jewelry, anything on their head, either shift it to the side or take it down so that you can really get a nice measurement at the top of their head. We review the rest of them, and then last, most important, is that if for some reason a child can't stand properly, you can always do an arm span, and I'll show you how to do that. Okay. Any questions about this? Fantastic. Okay. So abnormal growth can be characterized also by disproportionate growth. So 2 ways that you might assess this are the arm span and then an upper to lower segment ratio. You can also do a sitting height, but I actually don't have a slide on that. But conditions you might see disproportionate growth, somebody who has scoliosis, somebody who has a skeletal dysplasia, Marfan syndrome, and a number of genetic conditions are associated with disproportionate growth. I think the skeletal dysplasia that always comes to mind is, does anybody want to guess what the one that always comes to mind? Achondroplasia, you got it, yep. So arm span. So this is fairly easy to do. So you want to have the child stand. I like to have them stand up against the wall, and I usually will have them stand up against the wall like a corner. So I might have them standing up over here. Now this might interfere, so you'd want like a flat wall, and you want them up in a corner, so that way they can have their middle finger right here, okay? So that way you've got a fixed point, right? Kids tend to do this, they do this, they do this, so you really want one in a fixed point. It's nice to have another clinician, either a nurse or a parent or somebody else, help you hold the other hand, okay? And so, can I get a volunteer? Come on over. Okay. Actually, I need a second volunteer to help me hold it. This is probably not the best example because we've got the painting on here, but you can turn around. You can do it this way. You can do it the other way. Yep. And so you want to have the arms stretched out. Yep. There you go. And then we'd have another parent or a caregiver or a nurse or somebody helping us to make sure that this is staying in one place. And then I just make sure everything is nice and flat. And then you measure to the other side of the middle finger, okay? And then what I usually will do, thank you both for volunteering. So what I will then do is have the child step forward and then step back and do it 3 times total so we can make sure that it's accurate, okay? And the kids kind of like doing it because it's kind of fun. We tell them it's their wingspan. Anything to entertain them, right? So the second measurement that we can do is an upper to lower segment ratio. So this one, you need to know what the standing height is first. Then you put that aside. Your next step is to measure the lower segment ratio. So again, we mentioned light clothing. So children should be wearing light clothing. I usually have them stand up against the wall. We won't do volunteers for this one. And then you feel for the top of the pubic symphysis bone. And then you put your measuring tape at the top there, and you drop it to the floor. And that will give you a lower segment ratio, okay? If you subtract the height, if you subtract the lower segment from the height, that will give you the upper segment. And then if you divide the upper by the lower, you now have a ratio, okay? And so what do you do with that number? So that number generally falls somewhere between the range of 1.8 or 1.7 to about 0.9, okay? And you can plot it on this nomogram, and it will tell you where they should be based on their age. So when you think about babies, babies typically have a higher upper to lower segment ratio versus as they sort of march through, as they grow and move through childhood and adolescence, you can see that that ratio declines until they get to just about the age of 9, maybe 10 for a girl, and maybe right around like 9.5 for a boy, and then it begins to drop. And you can see that boys drop a little bit, and then they come back up. And this is representative of, again, adolescent growth. So if you think about a growing teenage boy, often you'll see the sort of lanky arms before you start to see that they grow into their body. So that represents that. Okay. And so there are different conditions that may have abnormal arm spans or upper to lower segment ratios that you can read through separately. So how do we do the growth assessment? So we talked about obtaining all these measures. We talked about when to do the growth assessment. Now we want to talk about the actual assessment and evaluation itself. So I think of this as a 3-step process. When you assess the growth curve, you should ask yourself 3 questions. What is the height expectation? Is the growth progressing as expected? So these are 2 points, right? Height is static, growth is dynamic, right? So you want to ask yourself about both of those. And then lastly, if either the height expectation is off or the growth is not progressing, why? Are there any clues to an underlying condition? So we'll start with the height expectation. So remember 13, right? So how do we calculate what the child is supposed to be? So it's helpful to know what the parents' heights are. By knowing what the parents' heights are, you can estimate a general range of where the child should be. So for boys, done in centimeters, you want to essentially average the height of the parents, but you want to add 13 centimeters. So in this case, mother's height, 13 centimeters, dad's height, and divide that by 2. For a female, you want to subtract 13 centimeters. So we generally, it's somewhat arbitrary, but dad's height minus 13 centimeters, I always call that adjusting dad to be a girl, but you're not really adjusting it, you're just taking that into account. And then you average it with mom's height. We usually will say there's about 8.5 centimeters variation on either side, but that kind of depends on how tall the parents are, right? So if you really, I don't know if there are any mathematicians by training or by interest in the audience, but if you really think about it, that standard deviation is going to be different, right? So if you have a very average height mother and a very average height father, probably about 8.5 centimeters. In my family, I'm 5'3", and my husband is 6'4". So there's a wide gap between us. So the standard deviation for our children is a little bit larger than that, right? So you're probably not going to calculate it, but this equation will get you close to it. So I've given you an example here. Your slides may say something different, and I apologize. I realized last night that I did the math wrong, so apologize. So please make sure that you correct the slide, okay? So in this case, if the mother is 164 and the father is 180 centimeters, then the expectations for any female child that they have is approximately 165.5 centimeters, or a son would be about 178.5 centimeters. Any questions about that? Yes?
In my country, much of the time we have both of parents during this.
Yeah.
Yeah. To take this like we've estimated what
Yeah.
they say, but
Yeah.
every time they
Yep.
correctly.
Yep.
Just skip this.
Absolutely. So the question is not both parents don't always attend the visits, right? So you cannot always measure it. So you bring up a great point that I neglected to mention. Oftentimes we're going based on reported heights. So we're going on what the mother reports that the father is, and it's not uncommon that you don't have the correct heights. So if you have the parents at the visit, it's ideal to measure them. But sometimes you have to go with what they tell you. Yes, so it's flawed. But we do the best we can. Is there another question? Yes.
Which is the best moment of the growth of the children to do this? Since the beginning?
So when is the best time to do this calculation? You can do it anytime. You can do it anytime. Mm-hmm.
And do you use Grealish atlas or also bone expression?
Yes. So the question is, do we use the Grulich and Pyle bone age atlas? And we do, and I'm going to show you that in a moment. We do, absolutely. So here, we're looking at a growth curve. Again, age on the x-axis, height on the y-axis, and we're looking at the height expectation. So you will see in some of my slides where I show a growth chart, often there is a bubble on the right. That's our institution's way of denoting the mid-parental height. And that's often based on reported heights, so to your point. But so here's a child who has a mid-parental height that is quite tall, right? But when you look at her height is progressing along that very bottom percentile. So this is an example of the height itself may not be abnormal. However, she is progressing slowly, right? So there's your mid-parental height, and that target is 170, but that's not where she is headed at this moment. So our next step is the growth progressing as expected? So here, growth is not progressing, right? We said we would expect the height to follow a particular channel, but this child is very clearly failing with regards to growth. So now, in this child who's failing with growth or has growth failure, do we have any clues to an underlying condition? Growth failure, particularly in this case, certainly may be a clue to an underlying condition. We want to make sure that we rule out systemic things, so not just endocrine conditions, but other systemic conditions. Any headaches, abdominal pain, vomiting, changes in vision. These things may relate to a GI disorder, may relate to a tumor, may relate to inflammatory bowel disease, celiac disease. Joint pains may relate to a systemic inflammatory disorder such as arthritis, right? Co-occurrence of chronic disorders or chronic inflammatory conditions, such as any of the ones that I mentioned, certainly can impact growth. Other contributing factors, we talked about disproportionate growth. So in that child, we want to get an arm span and an upper to lower segment ratio. Relevant medical conditions, if there's a history of intrauterine growth retardation. Now, this child was growing and then slowed down, so that's probably not impacting here. Or small for gestational age, or poor weight gain, or malnutrition. And I haven't shown you a weight curve yet. Medications can certainly contribute to growth failure. Frequent pulses of steroids, like prednisone. Stimulant medications may impact growth, just for some examples. And certainly extreme variations in puberty. So if I told you that that child had gone through puberty very early, that might explain why the growth slowed down, right? So it's, again, not necessarily normal, but it's a variation. Malnutrition, I talked about earlier, particularly in the infantile phase, but malnutrition may also have a delayed effect on growth. So this is the curve of a different child with malnutrition. So when we're evaluating, we want to think about what lab testing and evaluation we might want to do. So you've got particular clinical concerns on the left, and the lab testing to evaluate them on the right. And so you can see a complete blood count to assess for anemia or chronic infection, a sedimentation rate, celiac panel to assess for GI or absorption problems, comprehensive metabolic panel, calcium, magnesium, phosphorus to assess for liver disease, renal disorders, or disorders of calcium or phosphorus. Thyroid disease certainly would be evaluated with a TSH and a T4 or a free T4, and we'll talk about that during our thyroid discussion, as you will talk about the calcium in the adrenal with Dr. Calabria. Growth hormone deficiency, an IGF-1 and an IGF-BP3, or any genetic conditions, we might think about doing a karyotype or more targeted gene testing. Okay. So bone age. You asked about the bone age, so here we are. So how many of you are not familiar with the bone age? Oh, that's great. Okay. So bone age will give you an idea of skeletal maturity. And you want to equate the chronologic age to where the bone age is. When the bone age is younger than the chronologic age, we think of it as more time to grow, but then we also wonder what is delaying that bone maturation. On the other hand, if the bones are older than the chronologic age, you want to think about the etiologies for that as well. And so these are two different bone ages. I believe this is an 8-year-old on the left, although I'm not sure. I obviously didn't write it on the slide, so I apologize. And then on the right is a child who has near fusion of the growth plates. You can really see the difference. And obviously, the growth plates in your hand are not going to dictate your growth, but the growth plates in your hand are a surrogate marker for all of the growth plates in the axial skeleton. I have kids ask me that all the time. Does that mean my hand is done growing? Like, no, it's representative of your body. So this is the 4-year-old that I mentioned earlier who had malnutrition. So this child had slow weight gain, had slow height gain, and then you can see once the nutrition went up, the height really started to pick up. Right? This is a 10-year-old who had slipped capital femoral epiphysis, or SCFE. He was actually seen by orthopedics and treated for that, but orthopedics thought that he was obese and he was short, and so they referred him to us. And so you can see he's got pretty significant growth failure. And he came to us where those triple dots are. That was when he came to us. And you can see that his weight really picked up as well. So endocrine causes of growth failure often include excessive weight gain with slowing of the linear growth, but not always. So this particular child, we did do the full evaluation, and when we did his testing, we found that his TSH was greater than 1,400. So I think it was one of the highest TSHs I had ever seen. His T4, his total thyroxine, was undetectable, and he actually had positive antibodies. So we put him on treatment, and he grew beautifully. He grew really nicely. And it turned out he had autoimmune hypothyroidism. Even now, I think it's probably been about 6 or 7 years, he's developed no other autoimmune conditions, and he's growing beautifully. And so you can see that his weight kind of plateaued out. A lot of people talk about hypothyroidism and excessive weight gain, but we often don't really see children lose weight when we treat them. They just sort of stabilize their weight. So he did fantastic, and he's doing a great job. This is a separate case. So this is another child, an 8-year-old who was referred for short stature. So you can see he's growing. He had been maybe at that yellow line, and then he dipped even farther below. So we did an evaluation. There really wasn't anything remarkable on his exam. However, his bone age was quite delayed. His bone age was 5 at a chronologic age of 8, and his IGF-1 and his IGF-BP3 were low. So we were concerned about a growth hormone deficiency. So growth hormone secretion occurs in a pulsatile fashion. So if you look at the graph up on the top right, you can see that there are tiny little pulses and then a big pulse, and tiny little pulses and a big pulse. And so measuring random growth hormone is really not going to work all that well, right? Unless you happen to capture one of these pulses. Growth hormone, though, over time is going to increase with puberty. So as you start to make more sex steroids, you will get more growth hormone secretion. Growth hormone values, though, or growth hormone secretion will decrease with obesity. It's important to recognize that growth hormone is stimulated by a number of factors, including hypothalamic growth hormone releasing hormone, ghrelin, hypoglycemia, and exercise. And secretion can be suppressed by somatostatin, glucose, and obesity. And so these are sort of the pillars that help us decide how to actually test, or that are utilized to test growth hormone secretion by using growth hormone stimulatory agents or stimulation agents. When the pituitary gland makes growth hormone, it goes to the liver, and the liver secretes IGF-1. Despite these pulsatile and basal secretion patterns of growth hormone, the IGF-1 from the liver is very steady. So you can get a steady stream of IGF-1, and that is a very reliable way to measure growth hormone as a surrogate marker. However, IGF-1 is really important. It's really important to interpret it correctly. You must interpret it based on the sex of the child, the age of the child, and the Tanner stage. So if you measure the IGF-1 level for a 5-year-old, it's going to be a very different reference range than for a 13-year-old, okay? And same for a boy versus a girl. Also, and we'll get into this with the delayed puberty, if you have a child not going through puberty, who's maybe Tanner 1, maybe a 13-year-old who's Tanner 1, their reference range is going to be different than a 13-year-old who's Tanner 3, okay? And so they can look very low, but it's not appropriate for where they are in puberty. Does that make sense? Yeah, okay. It's also important to recognize that IGF-1 levels may be decreased with malnutrition. So that child I showed you earlier who had the plateau in the weight gain and the very low BMI, his IGF-1 was low for a very long time because of his malnutrition. Diabetes and hypothyroidism, untreated hypothyroidism also will lead to low IGF-1 levels. And so I'll mention this later, but if you have a child with hypopituitarism and thyroid deficiency and growth hormone deficiency, potentially, you need to treat the thyroid first and then reassess the growth hormone, okay? So when do you really think about growth hormone deficiency? It's ultimately a very rare condition. And so children who have congenital causes for growth hormone deficiency might include those who have poor growth failure, but perhaps a history of neonatal hypoglycemia, microphallus, maybe hypospadias, midline defects, heart defects, okay? A lot of children, as they start to get older and they're untreated, they have some frontal bossing. They can have a flat nasal bridge, and they may have a chubby body habitus. Sometimes their growth slows down, but their weight continues to rise, okay? Children with an acquired growth hormone deficiency, you might think of somebody who has headaches and is not growing well, or changes in vision, or if they're at risk for growth hormone deficiency, such as somebody who is treated with maybe chemotherapy or maybe radiation that attacks the pituitary. Okay. And our diagnostic tools to assess growth hormone deficiency include an IGF-1, an IGF-BP3, and then a poor response to the stimulation testing that I mentioned. questions? Am I going too fast or am I, okay, okay. A little bit fast? Okay, I'll slow down a little bit. So some causes for growth hormone deficiency may include syndromic conditions, Prader-Willi especially. There can be some specific gene associations, and then there can be anatomic abnormalities, such as an ectopic pituitary, septo-optic dysplasia, where the optic nerve and the pituitary don't form properly, or agenesis of the corpus callosum, so the connections between the two hemispheres. Acquired growth hormone deficiency, brain tumor, surgery, chemo, radiation, any of these causes, any destruction to the pituitary. So stimulation testing. So there are a number of agents that can be used. When we do pituitary, I believe on Friday, I have a very detailed slide that you can take a look at as well. The underlying reason for doing this is to really stimulate growth hormone to see if we can manipulate growth hormone secretion, to see if somebody can make growth hormone on their own. And the way that these agents do this is through a variety of ways. It might stimulate hypoglycemia, it might stimulate hyperglycemia, or it may have other effects where you stimulate growth hormone releasing hormone from the hypothalamus. And these agents all have varying side effects, between no side effects to low blood pressure to severe hypoglycemia. And again, we'll go through some of those in more detail on Friday. The pros for these artificial stimulation tests are that it can give you some information about circulating growth hormone levels. So that's the one pro. The cons are many. They're not perfect tests, unfortunately. They're non-physiologic. They're not particularly precise. The outcomes are based on pre-test probability. So if we tested all of us in this room, maybe about 20% of us would fail, yet we know we don't have growth hormone deficiency because we didn't need to take growth hormone, right? It's not necessarily reproducible, and you can see there's a number of other reasons. But the last one is probably the most important in that this is an invasive test. It typically requires the child to come into the hospital. They get an IV placed in their arm. They get baseline labs drawn, and then they get this agent through the IV or through a pill, and then they get serial growth hormone levels every 20 minutes for about 2 to 6 hours, depending on the test. So it's quite invasive and a little bit stressful, right? Just a little stressful. And it's potentially risky. There can really be some serious side effects from some of these tests. So we're going to come back to our case, right? This was our 8-year-old boy who had a delayed bone age, who was growing just below that yellow line, right? His IGF-1 and his IGF-BP3 were both low, and so we had suspicion for a growth hormone deficiency. So we did his stimulation testing. We want their levels to be above 10. His levels were completely undetectable. And so it turns out, so once we found that, we were very worried there was either a tumor in the pituitary gland or something else happening that was suppressing the secretion of the growth hormone. And so we did an MRI, and his MRI showed what's called an ectopic posterior pituitary. So you can see that bright spot, I don't know if you can see it or not, but you can see that bright spot is not in the right location, okay? And when the pituitary is not in the right location, what happens is the signals don't necessarily go correctly from the hypothalamus to the pituitary. And so that can be related to a growth hormone deficiency and various other levels of pituitary deficiency. So you could also develop hypothyroidism, as well as gonadotropin deficiency and ACTH deficiency. Okay? But in his case, he did have true growth hormone deficiency. And the treatment is to replace the missing hormones. So in his case, it was only growth hormone that we needed to treat. I don't know if you're familiar with growth hormone. I don't know what products are available in your countries. But the most common growth hormone that's available is a daily growth hormone, exactly. And these are injections. They're subcutaneous injections, so they're given with the same needle that you deliver insulin with. So they're very tiny, very small. I tell the children if it were to fall on the ground, I wouldn't be able to see it except that it's attached to a hub. Probably because I don't have great eyes either, but that's what I tell them. Very tiny needles, but very intimidating, right, to get a daily injection. And they may be taking this medicine for many years. Recently, at least in the US, about a year and a half ago, we received approval for a weekly formulation of growth hormone. Have any of you had these long-acting growth hormone products approved in your countries yet? Yeah, so okay, fantastic. So you haven't been using it, yes. It's hard to adopt new therapies, right? I find it very challenging. I'm always nervous with new therapies that something different is going to happen. But anyway, so it is a daily injection. There can be some side effects with both the long-acting and the daily. We haven't really used the weekly yet either. The long-acting is still pretty new for us as well. But the side effects are the same for both. You can get some headaches, particularly for children who are prone to headaches. They may get some growing pains, especially if they're growing quickly. They might get some fluid retention. I always say that is related to holding a pencil. So if suddenly your child has difficulty sort of curving their fingers to hold on to their pen or pencil, that may be fluid retention. And with these children, it's less than 10%, probably even less than 5%. I usually will have them stop the growth hormone for a little while and then restart at a lower dose and slowly increase to make sure they don't have the side effects again. And that's usually pretty effective. Serious side effects, though, can occur, and it is less than 1%, but it's important to know about. Related to fluid, you can get fluid around the brain, causing pseudotumor cerebri. That is an emergency. They do need to be treated. They potentially could go back on growth hormone, but that's a decision that you would make with the family. They also may get this slipped capital femoral epiphysis. You might recall this from the previous case a few slides ago, right? That child was not on growth hormone, but same condition. And essentially, the leg bone outgrows the hip bone or the pelvis, and so it slips out, and that can be an emergency. The child will complain of pain. The pain could be here, the pain could be in the knee, the pain could be in the ankle. Children are not very good at localizing where their pain is, right? Everything hurts here, right? But if they can't walk, or if they're suddenly limping, they need to go to the emergency room. This is not something that can be handled, or they need to get urgent care. This is not something that should be handled as routine x-rays. And typically, the orthopedist will put a pin on both sides to make sure it doesn't happen on the other side. Yes, question?
Is any clinical sign that help us distinguish the pseudotumor cerebri, it's an emergency, and headaches?
Severe headaches, very severe headaches. Maybe some vision problems, but very severe headaches. So I'm sorry, I didn't repeat the question, but the question is, how can you distinguish between a mild headache versus the pseudotumor cerebri? And that is very severe headache, worst headache of my life. And so growth hormone, the nice thing, and remember I said there are some treatments we have that will solve their problem. Growth hormone will get them to their genetic target. And so this child is doing beautifully. So what about short girls? I said I would mention it 100 times. I think I'm only at 97, right? So we always want to think about short girls because there is a tendency, for sure in the US, and I'm sure in many other countries and cultures, to think of females as short and cute, and it's okay if they're petite. But that's not necessarily always true, and many short girls don't want to be called cute, okay? So we want to make sure that we don't dismiss females for just being short. They need to be evaluated just as males do. And studies have been done that show that they are more likely to be more severely short at the time of referral and more likely to have a pathology. And so I showed you this slide earlier as well. So this is a girl who came to us. Again, her mid-parental height is 90th percentile, and she had been growing at the 5th percentile. So she actually had Turner syndrome, and she is now 13, and she is 5'2", and she is doing beautifully. So we always want to think about conditions that may impact girls and boys related to their short stature. Turner syndrome is particularly important because they can have cardiac issues that can be life-threatening. So to briefly go through growth in girls with Turner's, this is a growth chart, again, to orient you. Age on the x-axis, height on the y-axis for this one. The purple is our standard CDC growth curve for girls without Turner syndrome, the general population. The teal curve is a Turner syndrome growth curve. And you can see that the 95th percentile of an adult is approximately 155 centimeters in Turner syndrome. And the 50th percentile is 143 centimeters. But what's also striking is that the mean height of an adult woman without Turner syndrome is 165 centimeters. The mean height of an adult woman with Turner syndrome is 143, but I'll point out that the mean height of an 11-year-old girl is 143. Okay. So quite short. And so this is another child who was diagnosed with Turner's. Can you guess where the green arrow is, right? So, and we started her on growth hormone to help with height promotion. And so right now she's at 152 centimeters. So she's done well. And so lastly, we're coming to the end here. These are the last few slides, so hang in there. So we're going to talk about constitutional delay of growth and development. We call this late bloomers. I don't know if you have a term for it in your own countries, maybe similar. Same? Similar? Yeah? 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 Yeah. And so these children, it's normal growth, but it's a variation thereof. All aspects of their physical development are delayed. Okay? And this is often associated with a delay in puberty as well, and can be a lot more noticeable in children who are short to begin with. The solution or the treatment is have patience, right? To be patient. Very hard as a child, sometimes very hard as a parent. So in constitutional delay, in that pre-adolescent phase or prior to the age of puberty, their height begins to diverge even further from average children. So remember I showed the height velocity curve, and there was that prepubertal dip. So the children who are not going through puberty look like they're falling off the growth curve because they're in that prepubertal dip, and everybody else is in that acceleration phase. So now you've got this really wide gap between heights. Their height is slowing down at the same time as their peers are really speeding up. And if you were to look at their bone age, you would see that the bone age is quite delayed. Okay? Obviously, it's a diagnosis of exclusion, so you must rule out other underlying growth disorders before you can just say constitutional delay. And then as they start to go through puberty, they will start to have a growth spurt, which is typically later than peers. So now before they were decelerating, and now they're crossing percentiles upwards, and this is because now they're experiencing that growth spurt later. So everything is shifted to the right. Their height eventually returns to the normal adult range, but it's interesting. There have been studies show that children who have constitutional delay of puberty, they, for some reason, often end up at the shorter end of their mid-parental target. So that's it. Good things take time, right? So we've got a whole week ahead of us. I have a couple more slides that are just fun slides, so I'm going to pause for any questions. And I'm around, obviously, so if you have other questions or want to chat about something, I'm available. Yes?
Professor, for example, I use stimulation test.
Mm-hmm.
In some countries, they just perform two tests,
Mm-hmm.
different tests.
Mm-hmm.
And if patients also, second question, first question is,
Mm-hmm.
it's enough for only one test
Mm-hmm.
to perform,
Mm-hmm.
or should check two tests?
Right. So the question is about growth hormone stimulation tests, correct? And in your country, you use insulin-induced hypoglycemia to test for growth hormone secretion. So that is really the gold standard, because insulin will cause hypoglycemia, which will then should stimulate your pituitary to make growth hormone as a counter-regulatory hormone to raise the glucose. Many countries don't do that test, or many institutions, not countries. And the reason is that you do have to induce significant hypoglycemia, and there can be seizures, as I'm sure you've seen, or there can be very severe adverse effects from the hypoglycemia. And so for that reason, from a safety perspective, many institutions choose not to do that test. However, it is the gold standard. So that one test, if you can push them down to severe enough hypoglycemia, will tell you about growth hormone secretion. But not doing that test, the other tests have very low sensitivity and specificity, and so that's why we do two. Maybe two are better than one, maybe three are better than two, but that's why we do two instead. And so did everybody get that? I know I said that very quickly. Okay. So there are a number of agents. At our institution, we use clonidine and arginine. Yeah. Yes, and the second question. We do. So the question is, when you're in the adolescent age, do we do sex steroid priming, right? So we do have a protocol for sex steroid priming, so we do. And so the way that test runs is, the thought is, as I mentioned earlier, when you go through puberty, your body is making testosterone or estrogen, right, in the males and the females. And those sex steroids promote more growth hormone secretion. And so the thought is, if somebody is not pubertal or in the very early stages of puberty, can you adequately test their growth hormone axis if you don't give them sex steroids, right? And so by giving them their sex steroids, you're mimicking what their body would do during puberty. And so then when you do the stimulation test with the testosterone, or actually with estrogen, that should promote your growth hormone secretion and give you information about a deficiency. Does that make sense? And so we do that at our institution. I think many institutions do it. But whether you choose to do it for a particular patient depends on the patient. Yeah.
If you have not low dose estrogen, could you use spray form or gel form?
We use estrogen, usually estrace. I've never used a spray form for that. Are you talking about for priming?
Yeah, I mean.
Okay.
We have now 0.5 or 1 milligram hormone estrogen, and it's like could you use, gel form or
Yes, so our doses for estrace are 1 and 2 milligrams, but it might be a different formulation. Yeah. Question?
Yeah, I have two questions.
Yes.
One case you mentioned as more than the thyroid antibodies, more than 1,400. In that case, do we treat with steroids and only thyroxine supplement? How do you manage the autoimmune part?
We don't manage it. We really use the thyroid antibodies as a qualitative analysis for a reason for having hypothyroidism. We don't actually treat the thyroid antibodies in our practice.
What dose of growth hormone do we use for these TH deficiencies?
Right, so the dose for the growth hormone deficiency, I believe it depends by country. At our institution and in the US, we use between 0.2 and 0.3 milligrams per kilogram per week. So our calculation is slightly different than European dosing. I believe that is equivalent in Europe. I believe it's 0.2 milligrams per kilogram per week. But I may be mistaken. I'll double check that for you. There were some other questions. Did you have a question? Yeah.
What to do when we have low IGF and high IGF?
Yeah, it's a good question. I usually will so the question is, what do you do when there's low IGF-1 but high IGF-BP3? It doesn't happen very frequently that I've seen, but if it does, I usually rely more on the IGF-1 than on the BP3. So in other words, if the IGF-1 is low, I would proceed with an evaluation for either malnutrition or growth hormone deficiency or any of those conditions. Yes?
Do you use growth hormone for the treatment of STD children?
All right.
Because the age
Yeah.
you will wait for
Yeah.
follow up these children.
Right.
Starting with them.
Right. So the question is, do we use growth hormone for SGA, children with SGA, what age, and what's our duration of treatment? So most children will have catch-up growth from being SGA around the age of 2 to 4, depending. So typically, after the age of 3, I will say we have a harder and harder time with getting the insurance to cover the growth hormone, so that's one of our limiting factors. Yeah. And the doses are a little bit higher, but I think we're cautious now because there is some data that that came out several years ago through the SAGE group that was concerning for adverse effects with very high doses of growth hormone. It's individual. So continuation or duration of treatment is individual. Most families, once they start, don't really want to stop. Yes. Yes.
When we start treatment with GH, so should we have like an X-ray of the heat in order to detect this?
Yeah. So at the start of treatment, is that what you're asking? Right. So the question is,
The first year when they have like
yeah, rapid growth. Right. So the question is, when you start growth hormone, do we need to get hip X-rays? So we don't routinely do them. If there's a concern, so children who I might be concerned about might be children who have had chemotherapy or high doses of steroids for some reason, I might do an image of the hip as a baseline, but that is not typically part of our protocol. Mm-hmm. Yes.
Do you use growth hormone therapy for family with short stature, and in this case, should we perform stimulation?
Yeah. So the question is, do we use growth hormone for short stature, so familial short stature or idiopathic short stature, and do you do a stimulation test? We do use it. Again, it's very hard with the insurance companies over time to get the insurance company to pay for it, and it's a very expensive therapy. But we do use it. It is an indication. It's a question of who will pay for it. And in terms of stimulation testing, I mean, theoretically, if you don't think there's a deficiency, you wouldn't do the stimulation testing. But sometimes when you do the stimulation testing, if the levels are low, you may go down other avenues, or you might be able to get the insurance approval for it. So it's a little bit variable. I think it's individual based on the child. Yeah. Mm-hmm. Yes. Did you have a question? Yes.
My question is related to the effect of growth hormone in kidneys, because I have had a few patients with proteinuria after starting growth hormone.
So after starting growth hormone, interesting. So we have not seen that. We have seen hematuria after the stimulation testing has been done. But I would have to defer to my nephrology colleagues back there with growth hormone and proteinuria. I would imagine it's not common. So I would not do a kidney biopsy, that's for sure. But I might refer to nephrology for a kidney biopsy. Yes.
What about the children with the chronic kidney disease, their growth and therapy?
Yeah. So we do often end up treating those children with growth hormone. Yes. Yeah. Yes. So again, I don't know if it's country by country, but oftentimes children with chronic kidney disease do have growth hormone deficiency, and so we would treat them and see how they respond. Mm-hmm. Yes.
Maybe I didn't catch this before, but my question is there the age when we can, that the growth hormone can be prescribed?
Yes. So that's a really good question that I did not answer in my talk, and I will add this to my talk. Yes, absolutely. So the question is, if I understand correctly, is there a point where we cannot use growth hormone for treatment? And so there is, actually. Once the bone age in a girl is about 14, that's when there is fusion of the growth plates. And so growth hormone will not enhance the height or increase the height. However, if a patient has severe growth hormone deficiency due to some other cause, such as cancer or tumor or radiation, and they need some replacement for adult growth hormone replacement, then yes, you can use it, but it will not increase the height. And you need to be very careful to not give too much of a dose because that could cause some acromegaly, enlargement of the joints. Yep. So I will make sure to add that to my talk. Thank you for reminding me of that. Yes. Really just fun slides. Thought I would show you some pictures of CHOP since we didn't really have a chance to do this. So the top left is just an aerial view of CHOP. And it is located in Philadelphia, in the city of Philadelphia. And then to the right, this is a view at dusk of our main inpatient hospital. Down at the bottom on the right, this is one of our research centers. Maybe Dr. Firth is in this, maybe her office is in this building. This is the Abramson Research Building. And then on the left, on the bottom, is the newly built hub, which is where now many of the clinical offices are. So I know Dr. Calabria and I now live in that office. And Madura, I'm not sure where your office is. Or not.
Don't sleep there.
Well, don't live there, but yes. Although sometimes it feels like it. And then a couple more pictures. This bottom picture on the bottom, this is our ambulatory care center, Berger, that was just opened maybe about 4 or 5 years ago. And then up at the top are some interior pictures. On the top left is our atrium. So when you enter the main hospital, it's this probably 5 or 6 story huge atrium, and then those stairs go up to the 3rd level. It's pretty magnificent when you walk in. I was floored by it when I came to CHOP for the first time. And then that's the inside of one of our inpatient rooms. So thank you for your attention.